Hi, this is your discussion on the different diagnostic studies that can be used to evaluate our patients with neurologic problems. So there are different imaging studies that can be done for our patients. So we're going over them one by one. One is your X-ray. So class, your X-ray is used to evaluate for skull fracture. That's the main purpose of your X-ray. So if you would want to check if your patient has a fracture of the skull, it will not be your CT scan and MRI that will be the diagnostic test of choice, but your X-ray. Specifically, class, we are using your anterior posterior X-ray, your AP view, and your lateral view. So when I say anterior posterior, so the view captured is from this end up to that end, back portion. And when I say lateral view, that would be the side view of your patient. Now, there are two other views that are commonly used in the clinical setting. One is your Waters view, and then the other one is your Townes view. Class, your Waters view is shown on the left side of the slide. So your Waters view is also referred to as your occipitomental view. Your Waters view is used to visualize the maxillary sinuses. Meaning, class, it is used to check if there are opacities on the maxillary sinuses, and opacities on the maxillary sinuses would signal sinusitis. On the right side, you have your Townes view. Your Townes view, class, is an angled anteroposterior radiograph of the skull, and it is used to evaluate for possible medial and lateral displacement of skull fractures. In other words, if your patient would have skull fracture, it is your Townes view that will be used to evaluate whether this fracture has displaced to other parts of the skull. Okay, in addition, class, it is also used for cancer, okay, to evaluate if what are the changes on the cancer mass, and then also for your Paget's disease. Your Paget's disease is a disease of involving your bones. So I'll be discussing that in the musculoskeletal system. Then, this one, class, would differentiate how your Waters view and then your Townes view is being taken by the X-ray technician. So in your Waters view, the position of the head of the patient is like this. So that is what we refer to as your orbitomental line. Okay? But class, the plate for your X-ray is taken like this. Okay, the image of your X-ray is from the posterior aspect going towards the anterior aspect. So it is expected to visualize your maxillary sinuses. On the other hand, class, this is how your Townes view is taken. So notice the direction of the X-ray beam and then notice the direction of the head. Okay, so somehow the head is tilted forward and then class the patient is somehow facing downwards and then the X-ray beam is taken like this. Okay, meaning class the plate will be placed here. Okay, so your Townes view. The next diagnostic test is your spinal X-ray. So class, your spinal X-ray can be used to evaluate, of course, for fractures of the spine. It can also be evaluated or it can be used to check for osteoporosis of the spine. However, that would be usually on the late stages already, wherein the bones of the spine are already porous. So you have your anterior posterior view on the left side, and on the right side of the screen, you can see the lateral view. So again, lateral view, that's the side view of your spine. Furthermore, class, your X-ray of the spine could also determine if there is a decrease on the spaces here between your vertebrae. Okay, so there should be a space there, and the space is referred to as your intervertebral disc. Now, wherever there is a decrease on that space, it may result to the compression of the nerves, okay, which may manifest as pain or sciatica on the part of your patient. Okay, so that is what we refer to commonly as your spinal nerve compression. So that is your spinal X-ray. Again, AP and lateral views. Then we have your CT scan. Perhaps CT scan is among the emergency procedure or emergency diagnostic test that can be done if we are considering stroke to our patient. So class, CT scan is primarily done, okay, especially if we want to consider or to rule out the presence of hemorrhagic versus ischemic stroke. Class, for stroke, it should be managed within a certain time frame. Let's say, for example, within 2 to 4 hours. But the management for ischemic stroke would differ from the management of hemorrhagic stroke. Okay? For example, the administration of thrombolytic therapy could be done among patients with ischemic stroke, but contraindicated to a patient with hemorrhagic stroke. For us to determine if the stroke of our patient is hemorrhagic or ischemic, it will be your CT scan that should be done. Okay, other hospitals, class, would push that the CT scan should be done within 20 to 30 minutes upon entry of the patient from the emergency room if the patient presents with signs and symptoms of stroke. Now, So your CT scan could also be diagnosed for the following: intracerebral hemorrhage, your tumors, cysts, aneurysms, edema, ischemia, atrophy, and tissue necrosis with or without contrast. Okay, so class, it can diagnose structural problems within our brain. It could also check areas of ischemia because they would appear to be light on CT scan images. It would also be able to detect if there is a decrease in the size of brain tissue, also referred to as atrophy. So class, your CT scan could not be done for the brain alone, but it could also be done for the spine. Okay? Now, so on the slide are examples of CT scan images. Okay, this is particularly on diagnosis already, but just for you to have an idea, as you can see, the areas of hemorrhage would appear to be white. Okay, look at this. The first CT scan here on your upper left is actually a ruptured middle cerebral artery aneurysm. Then the one that you can see in letter D is a ruptured arteriovenous malformation. On letter E, so this is a classic appearance of a hypertensive hemorrhage. And then class for letter F, these are multiple hemorrhagic sites. Okay, so as you can see, the areas of hemorrhage would manifest as white. Okay, there are white, it is more white compared to the surrounding tissues. Okay, so this is the benefit of your CT scan. If you would look at it, your MRI will be able to give a more detailed image. However, class, your CT scan, okay, could be done faster. And in the management of stroke, we are more into giving a quicker management or giving a immediate therapy or treatment for the patient rather than to have the specific image. Later on, if your patient is manifesting still with signs and symptoms of stroke, despite the CT scan being clear, an MRI may be done. This would again be the differentiation of the CT scan of ischemic and hemorrhagic stroke. So class, your ischemic stroke would appear to be less dense. So class, this is the area of ischemia. So the area of ischemia would appear to be darker compared to the brain tissue surrounding it. Okay, then whereas the blood or the hemorrhage class would appear to be denser. That's why it would appear to be white on CT scan. Okay, for you to remember that, just think that the bones would appear white on imaging studies. So class, your bones have higher density. So the same principle applies to your ischemia and to your hemorrhage. Your hemorrhage has a higher density compared to that of your ischemia because we're dealing with blood here. So for that reason, class, it would appear to be denser on CT scan. So class, if you would look at this area of hemorrhage, now the bigger the area class of the hemorrhage, the less likely that the prognosis of your patient will be good. Okay, so again, the larger the area of hemorrhage, the poorer the prognosis of your patient will be. Now, CT scan. If your patient will be undergoing CT scan, cranial CT scan, there is not much of preparation unless if the CT scan will be done with contrast. Now, if the CT scan will be done with contrast, you need to hold your oral hypoglycemic agent for ionated contrast, okay, or for iodinated contrast. Holding your OHA will facilitate or ensure that the contrast will be excreted by the body after the test. Then, you need to orient your patient that they need to be in a stable position. They need to stay in place, okay, on that position for about 10 to 15 minutes until the CT scan will be done. Okay? Class, in cranial CT scan, the head is positioned in a cradle and then it will be strapped. So the purpose of that is for the CT scan to get a accurate image of the head. Okay? So they are being advised not to move around. Now, how about if your patient is uncooperative or combative? The tendency class is for the doctor to give anxiolytics or the tendency for the doctor to give sedatives during the procedure. Okay, the purpose again is for you to immobilize your patient. But still, that remains to be your dependent nursing function. You could not do that without the doctor's order. Then class, after the procedure, you need to monitor for delayed allergic reaction. So it's the same signs and symptoms with your allergic reaction class. Okay, your patient would have signs of hives, itchiness, difficulty of breathing, wheezing, okay, and then possibly hypotension if it is going towards anaphylactic shock. So you need to monitor for that. Then, you have your MRI. So class, you have your magnetic resonance imaging and you also have your MRA, magnetic resonance angiography. Class, your angiography could be done using your CT scan. It could also be done using your MRI. Again, between CT scan and MRI, it is MRI that will be giving you clearer images. However, for the purpose of emergency procedure, it will be your CT scan that will be the initial diagnostic test of choice. Okay, it will be your CT scan that will be the initial diagnostic test of choice. Now, so class, your MRI. your MRI is done for 30 to 60 minutes. Okay, that would be a plain MRI of your brain. So your MRI class is able to evaluate your brain, your spinal cord, also class your stroke, tumors, trauma, seizures, and your multiple sclerosis. Okay, that can be seen in MRI. So class, the image in the background is actually an image of an MRI. You might be wondering, or you might be thinking that the image of the MRI is somehow similar on that of the image of CT scan. Yes, class, the image may look the same. However, your MRI will be able to offer a lot of angles compared to your CT scan. Added to that, class, your MRI could perform several slices compared to your CT scan. Okay? So, class, again, MRI is done for 30 to 60 minutes. Then we have another variant of the procedure that we refer to as your MRA. So class, your MRA is magnetic resonance angiography. When I say angiography, we are evaluating the blood flow towards your brain. Okay, so in this case, class, if you would look at the image on your left, this is how a normal cerebral tissue perfusion would look like. Okay, notice class the white lines there. Those are indications of the blood flow going towards those parts. Okay, so as you can see, this is your circle of Willis. And then the patency of the blood vessels are very evident. Okay, as it supplies the different lobes of the brain. Looking at your basilar arteries and even your vertebral arteries here. If you would look at the next image class, this would show that there is a block in this part of your MRI. Okay, so class, as you can see, there is the patency of the blood vessel here is in question. Okay, why is it that the dye is not proceeding to this part of the body? Okay, so class, this would mean, okay, this would signify that your MRA is using dye. So, other than the preparations that we use for a usual patient undergoing magnetic resonance imaging, we also need to consider that our patients will be using contrast. Okay, so we evaluate our patients for the use of contrast. So meaning allergy for seafoods, allergy for iodine, and then if there is possible allergic reaction, you need to refer to the doctor. Other than that, we also need to check for creatinine. Remember, any patient undergoing procedure with contrast should be evaluated for kidney functioning. In that case, class, you'll be using your creatinine. If the creatinine values are high, okay, the test may be deferred or medications may need to be given, such as your sodium bicarbonate prior to the procedure. That is, if the physician sees that the procedure is very necessary for us to diagnose the patient, okay, in comparison to the risk that it may entail the patient. Okay, so it's a risk and benefit analysis. Okay, whether you would want MRI to proceed even if the patient is allergic or even if the patient is having some renal concerns. Next, you have your magnetic resonance spectroscopy. So class, your spectroscopy, okay, your magnetic resonance spectroscopy is still non-invasive. Okay, the purpose of which is to measure biochemical changes in the brain, especially in the presence of tumors. Okay, class, for your spectroscopy, just remember it talks about biochemical changes in your brain. Okay, if you would notice the diagram on the right, well, the images of the brain are taken, class. Okay, there is a specific diagram here which would monitor the levels of biochemical changes. So class, your MRS is used to diagnose, okay, or to evaluate for the presence of Alzheimer's disease. Okay, just for evaluation, because diagnosis of Alzheimer's tend to be symptomatic. Then extent of head injury from trauma or stroke, and then identify other possible causes of coma. Now, prior to procedure of MRI, you would be checking for claustrophobia because remember your patient will be exposed on a tunnel-like diagnostic machine. And then class, you need to evaluate for obesity. But most of the MRI would have a limit on the size of the abdomen that could possibly fit the machine. Okay, so you need to evaluate for obesity. Then class, metallic implants should be removed. Okay, that would include even your transdermal medication patches. So when I talk about your metallic implants class, this would include your clips on your brain aneurysm. This would talk about pacemaker. This would even include your body piercing, your tattoos, and shrapnels that could possibly be embedded inside the patient's body. Now, what is the reason for that? Because these substances could be magnetized by your MRI and could result to injury on the part of your patient. Now, for the transdermal medication patches. Class, your transdermal patches would usually contain aluminum. And aluminum is, of course, a metal. Class, once this metal or once this aluminum patches would enter the MRI machine, it may result to burns on the part of your patient. When the magnetic action class of the MRI will be acted upon that aluminum-containing substance. Then, pregnancy is contraindicated usually for MRI. Okay, especially if we're talking about pregnancy less than 20 weeks. Okay, because of the strong radioactive or the strong exposure to radiologic substances. Okay, so class, your cerebral angiography would look like this one. Okay, so as you can see, it is a map of the cerebral arteries. If you can recall our discussion in cardiology, we also do angiography in cardiology. So in this case, guys, we are mapping the structures of the brain. Okay, in that case, the blood flow to the brain. Okay, so for your cerebral angiography, the preparation for your patient would be to be on NPO for 8 hours. Then we assess our patient still for allergy because we will be using contrast for this procedure. After the procedure class, we will be forcing the fluids to our patient. Okay, forcing the fluids could be done per orem, it could be done via your IV, and the purpose of that is to ensure that the contrast will be excreted. Then class, we monitor our patient for TIA. When I say TIA, it's your transient ischemic attack. Oftentimes, these are referred to by lay people as your mild stroke. Okay, so class, in your TIA, you need to watch out for weakness, numbness, confusion, and slurred speech. Class, your TIA or your transient ischemic attack, the signs and symptoms would last for less than 24 hours. Okay, your TIA is actually mild compared to stroke. However, we do not underestimate it because the signs and symptoms of your TIA is similar to that of stroke. Okay, in that you could not conclude that it is just TIA without further doing diagnostic studies. Okay, so class, if we're managing patients with TIA, we oftentimes consider them already as patients with stroke, okay, to ensure that they receive the prompt care and management that they need. Okay, now class, for the allergic reactions, you still watch out for the delayed allergic reaction. So as previously mentioned, there may be itchiness, there may be tachycardia, dyspnea, and then you have your hypotension. Okay, common in allergic reaction. Then class, you have your EEG. If I am monitoring the heart of the patient, if I am determining class uh, the physiologic responses in the heart through your ECG, when it comes class to your cranial functioning, okay, or your brain functioning, we are looking into EEG. Now, class, when I say EEG, your EEG stands for electroencephalogram. Okay, it stands for electroencephalogram. Now, pre-procedure class for your EEG. By the way, notice on the previous slide that there are electrodes attached on the scalp of your patient. The usual question that you might encounter from your patient is that, are these electrodes invasive or are they inserted through the skin? So class, on that case, it's not. Okay, those electrodes would only remain on the scalp of the patient. Okay, now, prior to the procedure, you may need to withhold medications that can stimulate or depress the brain waves. That is, if we would want to diagnose for seizure disorder and epileptic disorders. Okay, if we are looking into epileptiform waves class on the EEG, these medications are placed on hold. Or else class, the EEG will appear to be clear despite the fact that the patient has an underlying problem. Okay, so class, the medications are placed on hold for 24 to 48 hours. Okay, as advised, of course, by the physician. So what are these medications? This can involve, your anticonvulsants. You have your phenobarb, you have your phenytoin. This can involve your tranquilizers, your depressants, your caffeine-containing food and beverages. So that would include coffee, tea, cola, alcohol, and chocolate. If your patient class will be taking, for example, coffee, chocolates prior to the procedure, the EEG may appear to be hyperactive. Okay, there may be epileptiform waves on the EEG, even if the patient does not have epilepsy, because these substances could trigger our brain. Okay, now they need to wash their hair class the night before the procedure, and then they are not supposed to use oil or hairspray. Among these patients class, it is not recommended also that they will be using their gel. It is not also recommended for them to be using wax on their hair because that would alter or that would hinder the attachment of the electrodes, okay, on the scalp of the patient. Added to that, you also need to orient your patient class that during the procedure, they may be asked to sleep. Okay, and then during the procedure, they may be exposed to blinking lights. The blinking lights is expected to trigger the appearance of your abnormal waveforms in the EEG. And this appearance class of the abnormal waveforms in the EEG would help diagnose for the presence of epilepsy. Prior to the procedure class, it is advisable that your patient would get adequate sleep. Okay, that would be 6 to 8 hours prior to the procedure. Okay, a night prior to the procedure. Then you have your PET scan. So class, your PET scan or your positron emission tomography is a technique that would use radioactive substances. Take note, it uses radioactive substances to visualize metabolic processes. Now, it would assess the normal brain function and also the cerebral blood flow. It is diagnosed, it is used again to evaluate certain types of dementia. So class, prior to the procedure, your patients are advised not to take coffee, alcohol, and smoke within 24 hours. Then you need to assess the glucose levels pre-test because class, very high and very low glucose levels could possibly affect the result of your PET scan. Then class, post-procedure, since we use radioactive substances, we would want to have fluids for this patient so that the radioactive substance would be excreted from the body. Then you have your invasive test. Okay, class, so your brain scan, your CT scan is considered to be invasive if we are using your contrast. Then you have, class, your lumbar puncture. There was an old name that was referred to as Quickensted's test. And then you have, class, your cisternal puncture, you have your myelography, and then your cerebral angiography. Class, I would like to touch first on Quickensted's maneuver. Okay, class, your Quickenstead test or maneuver is in fact a diagnostic test used for spinal stenosis. So what happens here, class, is that the patient would be placed on lateral decubitus position, and then the doctor or the examiner would try to impinge the flow of your cerebrospinal fluid, okay, in the lateral aspect of your neck. Now, class, if there are problems such as your spinal stenosis, okay, there will be a problem on the pressure of your CSF. Okay, as far as I'm concerned, this is already an old test and not anymore used at present. Okay, so that's your Quickenstead test. Now, other invasive tests would be your digital subtraction angiography. You also have your caloric testing. Plus, your caloric testing would involve the administration of your cold substance through your ear, and that would help to check for the presence of nystagmus. Plus, that will be an indication if the reflexes of the midbrain are still intact or not. Okay, so that's your caloric testing. Your muscle biopsy is, of course, getting a sample of your muscle through biopsy. And then, plus, we have your electromyography, which would be detecting the electrical impulses from your muscles. Okay, that's your electromyography. So these are all invasive tests. Allow me to go over some of them. Okay, so class, you have your lumbar puncture. So when I talk about your lumbar puncture, it's referred to as lumbar puncture because we are getting a sample of a CSF from the lumbar vertebrae. Okay, if you would look at the image, class, it would be between L3 and L4. Okay, that's your lumbar vertebrae. Now, the purpose of your lumbar puncture is to measure, okay, to measure the CSF pressure and to obtain the sample to be used. Okay, so class, the samples here is, of course, your cerebrospinal fluid. Normally, class, as mentioned, your cerebrospinal fluid should be clear and colorless. Its pH is at around 7.35. Its specific gravity is at around 1.007. Okay, class, there is some presence of protein. The presence of protein is at 15 to 45 milligram per deciliter. Plus, the presence of glucose is at around 40 to 80 milligram per deciliter. As you can notice, there is a higher amount of glucose compared to protein in the CSF because the primary food of our brain is your glucose. Okay, class, there is also presence of chloride here up to 132 mex per liters, and then the pressure is said to be less than 200 millimeter water. Okay, so those are the normal findings for your CSF analysis. Now, prior to the procedure, class, of your lumbar puncture, you are instructing your patient to void. The purpose of that is to prevent discomfort during the procedure because you would want your patient, class, to stay put during the procedure because the doctor would not want to puncture a different site of the vertebrae. And then, class, we are preparing your sterile lumbar puncture tray. So your puncture tray would include an antiseptic solution, usually, class, betadine, local anesthetic, sterile gloves, and tape. Remember that this procedure ought to be a sterile procedure. Okay, because your CSF, your spinal cord, your brain ought to be sterile organs. Okay, so there should be no penetration of microorganisms towards these organs. Okay. Now, during the procedure, the puncture, class, may be done between the L3, L4, and L4, L5. okay, or between this, and the fluid would be aspirated. Class, the test tubes that will be receiving the fluids should be labeled accordingly. So the first test tube, which reserves the first fluid drained by the doctor, will be labeled 1, okay, 2, 3, and then 4. Class, depending on hospital policy, there may be 3 to 4 specimen bottles that need to be filled up. Now, the position of your patient is your fetal position. What do I mean by fetal position? So class, the back is bowed, and then the head is flexed, and the knees is drawn up to the abdomen. This position, class, would help expose the spaces between your vertebral disc. Okay, so this would help expose the space between your L3 and your L4. Okay, now class, the extraction is of course done using your spinal needle. Next, after the procedure, after the lumbar puncture, class, you need to assess for the neurologic status of your patient. You need to watch out for the presence of fever. You need to check for hypertension, okay, because you might have innervated the sympathetic nervous system. And then class, irritability, and then lower extremity numbness or tingling, and non-reactive pupils. The irritability, class, may be a sign of increased intracranial pressure. It may be also, class, a sign here in your CSF. Here in your lumbar puncture, it is a sign, class, that there is an excess loss of your cerebrospinal fluid. Okay, numbness and tingling of the lower extremity may indicate that your spinal cord may have been severed during the procedure. Hence, the lower extremities are affected. Your non-reactive pupils is already a late sign, class, okay, of cerebral damage. Okay, you'll be giving analgesics if ever it is ordered by the physician for the pain that may be possibly experienced by your patient. And then the patient, class, would be positioned flat on bed, okay, in the prone or supine position for 4 to 8 hours. So class, the purpose why they will be placed on supine position is that, okay, you don't want CSF to be leaking. Leakage of your CSF, class, will cause what you refer to as your spinal headache. Okay, leakage of your CSF may cause spinal headache. So for that reason, your patient is placed on supine position. And then class, pressure is applied through the puncture site. Okay, and then we also watch out for hematoma formation. Then class, we need to instruct our patients to increase oral fluid intake. So by increasing oral fluid intake, that would be at around 3,000 ml in 24 hours. Then you have your myelogram. Class, your myelogram would be able to help us identify the lesions of your spinal cord. So during your myelogram, as the test would imply, okay, myelogram, okay, gram, there's gram there. So class, this is an imaging study that would involve the use of your dye. Okay, there is a use of your contrast media. Now, what is done during the procedure? During the procedure, class, a lumbar puncture will be done. And then, class, in this lumbar puncture, the contrast media will be injected. Okay, it will be injected towards your subarachnoid space. And then series of x-rays will be taken. Okay, if you would look at it, the images, sample images for your myelogram are shown on the back of this slide. Okay, so class, the purpose of which is to evaluate also for the structural problems on your spinal cord. Okay, spinal cord or spinal column. That will be your myelogram. Then, class, prior to the procedure, here are the preparations for your patient. You need to instruct your patient to increase the oral fluid intake. The patient would be placed on NPO for 4 hours. Then we withhold the following medications. Any antipsychotic, common for that is your haloperidol, any antidepressant, such as your sertraline, and any anticoagulant, such as your heparin and warfarin. Since we are injecting a contrast media to this patient, class, okay, allergic assessment or assessment for allergy would be important. Okay, you advise your patient that smoking should be placed on hold on a day, and then of course they need to void because the procedure may be prolonged. Okay, so class, they need to void in such a way that they will not be altering or moving around during the procedure. Post-procedure of your myelogram. So supine position still with the head slightly elevated, and the purpose of your supine position is still to prevent your spinal headache. Again, class, your spinal headache is caused by the leakage of your cerebrospinal fluid through the puncture site. Then, we need to increase the oral fluid intake of the patient after the procedure. Okay, why? You used contrast media. Then, you need to monitor for fever, excessive nausea, and vomiting. This may indicate, again, CSF leakage. Okay, then class, you need to monitor the neurovital signs of your patient. Although it says here that it should be done every 8 hours, class, okay, I would suggest that you do it more frequently, okay, every 2 hours prior, immediately after the procedure, and then class later on every 4 hours. Okay, that is for you to make sure that your patient's neurostatus is not deteriorating. Then, okay, so class, this is how a patient undergoing myelogram would look like. Okay, the preparation, class, if you would see, so this is application of your betadine. Okay, preparation for injection of your contrast media. Okay, then class, this is your cisternal tap. As you can see, class, this would get a sample on your cistern. Okay, so this is your cisterna magna, which could be found just above your cervical spine. Okay, so class, its purpose also is to do your CSF analysis. Okay, if you would look at it, due to its close proximity to the brain, this is usually used, class, for diagnosis of meningitis. The next test is your nerve conduction velocity test. So class, your nerve conduction velocity test, also known as your nerve conduction study, would measure how fast an electrical impulse would travel through your nerve. Okay, so class, this is specifically used to identify nerve damages. So usually if the nerve is compressed or if there are underlying nerve problems, this is the test that we use for our patients. Then you have your electromyography. Class, your electromyography would measure the electrical activity of your skeletal muscles at rest and during contractions. So your electromyography is used to evaluate for neuromuscular diseases. When I say neuromuscular diseases, that will be the time that we consider myasthenia gravis, okay, you consider your amyotrophic lateral sclerosis, and then your multiple sclerosis. So you have MG, ALS, and MS, the neuromuscular disorders that we will also be tackling about. Prior to your procedure, class, electromyography, the following will be placed on hold: caffeine, smoking. It can be done 3 hours before the test. So if you have noticed, class, no, in the diagnostic test here, anything that could possibly affect the functioning of our brain, anything that could stimulate our brain or depress our brain functioning, are usually placed on hold prior to the procedure. Okay, we also place on hold, class, your muscle relaxants. So that would include your anticholinergics and even your cholinergics. Because take note that these medications would have an effect on the muscular functioning of our patients. And we don't want that to be altered during the procedure. Also, class, prior to the procedure, you need to obtain the informed consent of the patient. Okay, that is true for all of your invasive procedures. Now, during the procedure, class, you would expect that needle electrodes will be inserted into the skeletal muscles. Okay, it is usually the skeletal muscles of the arms and the legs that are being used for evaluation. But then that would depend on the symptomatology of our patient, and that would also depend on the disorder that we are trying to rule out. Now, class, the movement of the muscles would be recorded using an oscilloscope. And then this will be recorded on a graphing paper in such a way that it would appear like a tracing. Okay, so normally, class, there is no electrical activity at rest. If there are electrical activities at rest, we would perceive that there is hyperexcitability of the muscle. Then we explore the neuromuscular problems associated to that. Okay, class, that will be all for the diagnostic procedures. Thank you very much for your attention.